Good morning again, and thank you. So, I've been involved in alcohol and pregnancy for about 10 or 12 years, and over the last 2 years, opioid and substance abuse in pregnancy. I did train in buprenorphine as a prescriber, and I began a program of seeing women who are opioid addicted in pregnancy at Stony Brook. Why I'm here and what I want to say is that our specialty for OBGYN needs to address this urgently and not run away from it because it's there. The patients are coming in, they're coming in withdrawing, they're being seen in our offices, and we need to address this head on instead of turning and running. And it may sound, you're all here, so you're not turning and running, but there are many providers who just don't want to deal with this. Secondly, our training system, so our residency programs and down to the medical schools, I also have to address this situation. And so I agree with what the Lieutenant Governor said, what Dr. Kaufman said, that we need to begin to focus on how we improve this. I put up here as one of the first things that, so I was asked to sort of talk about care, and I don't want to get into what I wrote up there. We included in your, at least in the email, you should have received the reference that I used here, which is a Stanhope article, which very nicely overview of management of pregnant women with opioid use, use disorder, and how to address it. One of the things that I found coming to Stony Brook was that we often see women withdrawing. They show up in labor and delivery, and you want to call psychiatry to help you out, they just don't answer the phone. They're just not available. And that you'll see in my resource slide at the end, that's one of the problems is who do we turn to? And here we have the patient in front of us. So we need to say, well, how do we universally approach this problem? In all our hospitals around the state of New York, and say, well, let's put together something that says, here's what we're going to do when these patients show up. And so I put up sort of some initial treatment. I prefer buprenorphine over the methadone, and that has to do with the availability of resources is greater with buprenorphine than the methadone. The methadone requires patients to travel to certain locations and makes it more difficult for them. But as far as looking at outcomes of both are acceptable management. So I added in here, and Dr. Kaufman mentioned it, these are just some of the adjunct medications that are required. I didn't really put in any cookbook way of addressing these patients when they show up in labor and delivery, but the article does approach that, and you need to make sure you do a urine toxicology to see what other substances the patients are using so you can address all the issues. Now, what the main point of why I'm up here and what my little focus of this panel is looking at the patients. So what is, here we have the patient side of things. Here's Mrs. X or Miss X, and what does she have to say? And what are the issues that she has? And what do the patients ask me every day? One thing I'll just say, in the last 14 months, we had 2 maternal deaths related to opioid overdose. Both women had delivered their babies. Both babies were still in the nursery, and both women overdosed on heroin, I believe. A very tragic thing, and actually brought together much of the hospital, especially the nursing, together with the NICU people and the pediatrics. So kind of brought the labor and delivery and the pediatric components together to just talk about this. And from our side of things, we have to look at this and say, well, these women, how did they get there? Well, we can't account for that. Our Lieutenant Governor mentioned, the overprescription of opioids for pain, whatever way you got there. However, this woman got there. That's part of her story. But now, how do we help her? And how do we change the course of her life in a better way? One of the questions they ask us is, or ask me, is, am I hurting my baby? And I've heard this from the acute withdrawal patient in the triage unit to just the patient in the office. Common question, am I hurting my baby? And I try to be reassuring to them and tell them that you need to get into a program if they're not already in one. We need to remove the other substances you're using and keep you on one opioid and at least get you to the best place possible. One of the things that I've noticed is the triggers. I put that up there. What are the triggers? I will tell you that most of the triggers is the significant other. The significant other is often also using and brings them and sucks them back into that bad behavior. The family often adds support, but those triggers, so how do they address this and recognize where to go in their own life so that they can avoid returning to bad behavior? Pain management. Every single one of the patients ask me, I'm using an opioid, so they're not going to give me any pain medication because I'm addicted. And that is actually, as OBGYNs, we need to address that very, very well and involve anesthesia. These women, actually because of the changes in the opioid receptors, may in fact need more pain medication. If they're on methadone, they should remain on methadone throughout labor. If they're on buprenorphine, the same. They should remain on the medication through the labor process and postpartum. That we have to involve the anesthesia and make sure that they understand where these women are coming from and that they have some sense at all our institutions. I'm not going to speak much about neonatal abstinence syndrome because we have the next speaker is going to address that. But what do the patients ask me? How long is my baby going to be in the hospital? And what's going to happen with my baby? And I Child Protective Services coming. And I tried to answer that with, yes, your baby is staying in the hospital, because I'm not going to tell them some fairy tale. It's your baby's going to be in the hospital maybe 2 weeks, maybe a little shorter, maybe a little longer. It depends on how your baby responds. And that, yes, the social worker is going to be involved. And yes, you're going to be drug screened when you're in the hospital. And if you're in a program and you are doing the things you're supposed to do and your home environment is acceptable, Child Protective Services are not going to be an issue for you. I try to tell them that so that they understand what they have to do in their individual lives. And lastly, I put this up because we all need to be attuned to the stigma. This involves nursing, physicians, clerical staff, whoever it may be, whether you're in the office or you're in labor and delivery or wherever you may be, or actually even in the hallways when the baby's still in the nursery and the patients are returning, they feel this stigma which occurs when they come back to see their baby who's on opioid hold or whatever terminology you want to use in each hospital. But they hear what people say, and it makes them feel uncomfortable. It makes them feel less of a person. And we, as providers, need to make sure that we are curbing that. That these women didn't come there because they chose to be there. However they got there, they're there. We need to sort of, as I said before, direct them in the right direction. And part of that is making sure that we aren't having these small side conversations. And lastly, the resources. The lower part there just is some Long Island resources that I have that I use. But up there pretty much mimics what Dr. Kaufman said, that there are limited places for pregnant women, especially over 20 weeks, for women to receive care who are addicted. That our psychiatric colleagues are, as I said before, less than helpful. And we need to really look at the social service support system and how we can get them into programs. I was happy to see what Dr. Morgan put up today as a real-time type of, and I wrote that down, that website, to sort of look where programs are available. I'll say thank you very much.